whys and wherefores of why we put IVs in the way we do. Mostly this is infection prevention. And part of the reason for that is it's really important to know that the insertion of an IV can set someone up for actually death. We had a lady come in, EMS, IV placed, comes in, goes to M5, and through nobody's fault, the IV was never recognized as an EMS placed IV, so the IV sat there. What was done was it was charted, which oftentimes they are not, but this one was charted and the removal date was charted for the next day. Apparently someone said, oh well that's wrong because it was inserted like on the 17th, we don't take them out for 4 days. No blue slip was generated, so we never saw the patient. They were here 4 days, 2 interventions were done cardiac-wise. On the 4th day, they were getting ready to go home. The white cells were starting to elevate. The heart rate was going up. She was slightly febrile. Took the IV out. She went home. Now, everybody knows about biofilm and all that. Okay. So it was probably cooking.
I don't know about biofilm.
Every time you put something in someone's body, biofilm forms. And bugs can hide in that and multiply. It's nice and warm. There's access to blood, but your body doesn't really see it because of the protein film that's made around the little bugs. So when we pulled a catheter out after about 4 days, the theory is that this goes somewhere in the body and with the biofilm and continues to multiply, the bacteria increase, and then you see the infection. Well, so she goes home. 2 days later, she's in with full-blown MSSA bacteremia. She died. So it was an EMS-placed IV, and not throwing EMS under the bus, but they're put in rapidly, oftentimes just with alcohol. And so that's kind of where this whole thing is based around, is that one particular event. There was another patient that also had bacteremia. We're not sure what the cause of that was, but this patient had 5 IVs in 2 days, and each IV that was put in required 2 or 3 tries. So that increases the risk for an infection too. So, but we can't absolutely say it was that because there were other interventions done while she was here. So that's serious complications from IVs. So infection is the big one that I'm going to talk about today. And then there's the other ones, thrombus, phlebitis, nerve injury, which results in a lot of lawsuits, infiltration and extravasation. I know you don't deal with a lot of infiltration and extravasation, but it's nice to know where to look if this happens to you. So infection. CDC and INS recommendations are prep the skin with chlorhexidine, 70% alcohol, and at least, they say 0.5, but really everything in this hospital is 2% or greater. Limit the number of IV attempts because we know when it gets hard that we start palpating and doing things we shouldn't do to insert an IV. And the big thing is avoid site palpation after you've done the skin prep. And then once the IV's in, of course, everybody knows the 15-second alcohol scrub. And now they're saying that if you use a chlorhexidine swipe, they have those now, they're a little more expensive, that it's a 5-second scrub and a 5-second dry to decrease the risk of an infection. And of course, remove all field-placed IVs as soon as you can, because you can't verify the conditions in which it was inserted, and not everyone uses ChlorPrep. And there's a big hoo-ha now about should we remove all outside hospital IVs. No one recommends that, but one of our policies says we should, and that's our policy, and I tried to change it 5 months ago, but it's kind of in limbo. So that'll be to come. We're rewriting all of the peripheral IV policies, putting them into one. Yay! So that'd be nice.
So at this point, Anne, we should remove all outside hospital
that hasn't
IVs.
been put out. Now, the infection control policy says no. They only address EMS. Ours was written before the infection control policy was written, and it's not supported by any science that we should do that if ChlorPrep was used on the insertion. Now, if there's any leaking, pink, any kind of funny looking site, pull it out. That's what we all do, pull it out. If it's leaking, bloody, just pull it out. You're safer that way. So chlorhexidine, I love chlorhexidine. Yes, it stinks, but It's a broad spectrum antiseptic. It kills everything except 1 or 2 viruses. It kills fast, it kills in 20 seconds, and it's persistent on the skin. So if you have a 2% chlorhexidine prep, it stays on the skin, it sticks to the protein for up to 48 hours. There's some that are stronger. You guys use these?
Yeah.
These are really meant for central line insertions, so they're great. They're soupy enough to prep for what I mean is they're a 4x6 area.
Yeah.
So they're soupy enough to prep for a peripheral IV. Better is better. I mean, it's better than just a small swab. These, up to 7 days of persistence on the skin, which is good. Alcohol is short-lived. There's no persistence on the skin. Once it's evaporated, there's nothing that keeps the germs from growing except a sealed environment. And comparing it to propione iodine, which used to be the one of choice, it's about 50% more effective. I'm talking about ChloroPrep. So now neonates might be sensitive, and people with sensitive skin might be sensitive to ChloroPrep. So you probably, if you have 2%, use 2% if someone's already a little pink or whatever. And then there is the skin prep that you can use to put the dressing down. I don't know if you guys have that. But
No.
it's a wonderful thing. It's sterile. If someone's hairy, you rub the skin with that and it'll stick. You don't have to shave them. And then with alcohol, it breaks. So we're not even pulling their hair out. You just have to use alcohol to break the seal. Or one of these, because they have alcohol in them.
Can you tell me again how long we clean with that chlorhexidine? How long
30
it's dry?
seconds, and then until it's dry. No less than 30 seconds, but at least 30 seconds dry time. But till it's dry, because some people, you know, they take longer to dry than others, so. Let me clicky, there. So you prepare the site. This is, again, the persistence. 50% reduction over propione iodine, just reviewing, it's important. Scrub for 30 seconds. If it's in a wet area, if they're sweaty and you're putting it in the anticube, go ahead and scrub longer. Scrub until all your juice is gone. It'll be about 2 minutes. If someone's groin, we scrub for 2 minutes and then let it dry. And you let it dry for as long as it takes, but at least 30 seconds. And friction and saturation are the key. You don't have to do the old-fashioned circular thing. You know, remember that? With the propione iodine, round and round. And then you get another stick, round and round. You don't have to do that anymore. It's friction and saturation, and then the dry time. First choice here by policy is ChloroPrep, and then it's propione iodine, and then it's alcohol. And you can, anytime you want, if you have any questions, or you think of something. Here's the thing, those gloves in the little boxes on the walls are filthy. You don't know if somebody pulled one out and it fell and they put it back. You just don't know. So we always talk about them as being dirty gloves, not in front of the patient. So don't be manipulating your catheter, and don't touch the site. I don't know who marks. Some of us mark, well, most of us mark. Most of us mark our vein. Some of us mark with our fingernail before we scrub. Some of us mark with, this is nice, but it's a lot bigger than a fingernail, so you have to pay attention which side. This, if you hold on the skin, doesn't really hurt, and it persists for about a minute. So I tell everybody I'm training to find the vein, pull traction, see where it is, with the traction pulled, mark. And then pull traction again and make sure your mark is where you thought it was, and pay attention to which side of the little oval your vein is really on. And then you can make a mark another inch up so you know which direction you're going in. I find it very, very helpful. We have 2 new people on the team, and they're slow, but their technique is really good because they don't have to manipulate or palpate. I tell everybody put a dressing on before you remove the stylet, because then you can hold pressure and you're not contaminating the site. Why do you do that? Because most early infections do not happen through the inside of the catheter lumen. What happens is a bug gets under the dressing and goes, oh gosh, it's warm over there and wet. Over there is where the catheter is. So they travel, this is in my mind, they travel to the outside of the, yeah, a lot of stuff goes on up there, you don't want to know. They go to the outside of the catheter, it's warm and wet in there, and they travel down into the bloodstream. And of course, by now there may or may not be a biofilm on the catheter. We don't know. You can't see them when you pull them. Only pics sometimes you see them. Goes in there and starts multiplying. So we want to make sure they can't make a home under that dressing, and that's why you also use skin prep if someone's hairy. You've seen the floating dressings, like the floating floors, they don't really touch the floor. So, and bugs get under there and go down the outside of the catheter. It's estimated that 60% of all infections are extraluminal the first week of any line insertion, so that's pretty high. Avoid palpation, big deal. You can use the end of the catheter if you don't want to use your ChloroPrep stick, you know, this little thing, because you can put like a half circle down there instead of a great big target. You can use your fingernails. Some people don't like to do that. My hands are clean, and I can't feel with the gloves, so I do all that before I prep. And make sure you mark with traction applied. It's a big deal not to touch. Whoops, I'm so good at this. I can't see either there. Size matters, size matters, size matters, size matters. I cannot say that enough. These are the gauge catheters, 16 gauge, 18 gauge, 20 gauge, and how many mils an hour you can give. And I say size matters because I read all the INS stuff, Infusion Nurses Society, and they say that the smallest catheter that will deliver the therapy is the one you should choose. Of course, you're not going to put a 24 gauge in to give someone some blood because it'll take you forever. But to decrease the risk of thrombus, extravasation, and infiltration through hemodilution. I assume everyone knows what hemodilution means, but the best way to describe it is two pipes. You have a pipe which is your vein, and the pipe which is the catheter. If you put a big pipe in a little bigger pipe, then you're really slowing the flow of the blood around the catheter. When blood slows down, thrombus form. When thrombus form, it helps biofilm to form. So infection increases, the risk for extravasation and infiltration increases because there's only like 4 infusates that are osmotically the same as blood. They are like D5, normal saline, LR, and blood products. So if they're hypotonic, then they pull fluid from the little cells that line your vein. And if they're hypotonic, then the little vein wall cells absorb the fluid and burst. So you're kind of between a rock and a hard place. You want as much hemodilution as you can get to prevent extravasation and infiltration. Because pulling water out of that one layer of cells that lines your vein harms the vein. It no longer is a closed system. It opens up, and then you get the extravasation and infiltration. And just FYI down there, red blood cells pretty small. The biggest one is 8 microns, and the inside diameter of a 24 gauge needle is 300 microns. So a lot of people say, well, I can't get blood through a 22. Yes, you can. Our policy says you can't. It recommends 20 gauge or bigger, and that comes from probably way back when we hung all the blood. I don't see a lot of old people like me, but when you hung blood by gravity, yes, it won't flow very well in anything less than a 20, but we're using pumps now, so it will flow.
A question or a comment in terms of the gauge and what we choose.
And I know you guys are in a different place.
Okay,
Yes.
I just wanted to,
Yeah.
comment that for anesthesia reasons and OR reasons, I would think it would be best to put in the
It
largest
is for
you can.
resuscitation.
Yes,
Yes.
because you want to be able to give a
Yes.
high volume when we need
Right.
to. We just,
Right.
not to forget that fact.
Exactly.
Yeah.
And I agree totally. Sometimes we'll have someone going for a TAVR or another procedure, and it's a big procedure, it's open heart procedure, and we will try to get a 16 and we can't. So we'll go with an 18 or 220s and because we can't fit it in the vein. So I mean, I even go up with ultrasound sometimes because we just can't find a vein, so. And we get that. We understand why you want the bigger catheters. But consider the length of the catheter stay too. If someone's coming in for a procedure that you think they're gonna bleed or whatever, big catheter, and then they're gonna go home, good. If that catheter's gonna dwell for any period of time, it really increases the risk for thrombus and everything else with a larger catheter. So there's a lot of litigation around nerve damage for peripheral IVs. The brachial nerve is a big one. It runs right along the artery, sometimes in between the artery and the vein. So if you ever stick someone and they have tingling in their hand, you need to take it out right away and document. There's nerves that lie very close to the wrist here. And you want to avoid those. So these two areas, 3 fingers, I'm sure you've heard this before, and the wrist. And then inside the arm is where the brachial nerve is. And that's a big one that a lot of litigation surrounds that. So you want to be sure that you avoid these areas when you can. And this is always a bad place unless they're getting a CT scan. The reason they put them here for a CT scan is because just like on the picture, and I've seen this in ultrasound, the vein, as soon as you get to the antecubital space, multiplies by about 3, the diameter of the vein. So it's a wonderful place for a CT scan, but not so good for anything else because every time they bend their arm, the end of the catheter hits the vein wall. So. You don't deal with a lot of extravasation and infiltration in pre-op, I'm assuming. But there's a wonderful drug, it's called a hyaluronidase, and it is an enzyme, and it breaks down the hyaluronic acid in the body, allowing for dissipation of edema. I can tell you another horror story. 18-month-old baby, black hand, had an IV right here. They were giving a fluid bolus and the regular IV fluids at about 300 an hour, which if the IV was working would be okay. Well, it wasn't. It's very hard to see an infiltration in a baby, and a fussy baby you don't notice. So we go up, the hand is black. The doctor's sitting there looking at me, the mother's looking at me, and I go, hyaluronidase to the doctor. She goes, huh? And I go, tell the pharmacy you want hyaluronidase. There's circulatory compromise, it will dissipate the edema very quickly. She calls the pharmacy, they go, you don't need that, that was LR. And she goes, well, it won't hurt, right? No, it won't hurt. So we give the injections, within 10 minutes, the hand's pink again. So it's a wonderful drug, and there's, PACU had a couple, the same kind of situation, purple hand with an adult, hyaluronidase. In 10 or 15 minutes, the hand is pink again and warm. So that's a beautiful thing. It's a beautiful drug.
IV or IM?
No, so cute.
I was gonna say that.
You give it around the edge of the site, and that's what you would call us for. Just call us because we do it. If one of us doesn't want to do it, we'll tell you how to do it. But it's just around the edge of the site. Sub-Q. Very little needles, 5 injections.
We had I'm just wondering if this would be a case to give that, or does it have to be more severe? So we had a baby recently arrive with a pump running with an IV in the head, and I looked right away and saw it was completely infiltrated on his head, like a big bump. Was that, but it wasn't black, I mean, nothing like that. So we just stopped the fluid, took it out. But would that be, would you want to do that because it's the head, or no?
You would want to ask. If it's painful, then you would want to ask.
It was a baby, so
yeah.
It wouldn't.
And now, at my former hospital, we did it a lot with babies because we were afraid for babies.
I was afraid for this baby.
Absolutely, and that's why I bring it up, because it's a really big, it's a lovely drug. I love it. Some people have a sensitivity to it, but very rarely. And all you really do is 5 around the site, the edge, and chloroprep the whole thing. And usually people don't really feel it because the skin is so tight and it already hurts so much that every time I've given it, nobody even winces. So, yeah.
It's the same needle?
No, 5 different needles. Yeah, they'll send you a thing, you'll pull it up in like little insulin syringe. Yeah. But again, you can call us for help with that. They have a wonderful, it's the best policy I've ever seen here on infiltration and extravasation. And it's a nursing pharmacy policy, and it's 117. But it is great because it tells you what to do for almost all infiltrations and extravasations. They have a table and for blood and everything. And then another thing, if you want to get a hold of us, a lot of people call this pager, the 126 pager, yeah, that's the charge pager. And that's good at night, but not during the day, because then you're going to go through 2 people before you get who you want. So 123 is the pager you want to be called to get our help for stuff like this. And then tips for insertion. If you have trouble visualizing a vein, for me, I use a alcohol wipe and wet it down, and then I can see it. Because for some reason it looks shadowy if it's not wet, to me. If I'm not sure if a vein is competent, I do this, empty it out and see it fill again, and that's also a good way to tell where the vein is. You eyeball it when it fills, you go, oh, that's where it really is. And then it does ensure the vein is patent, because sometimes you'll do this and the blood won't empty out and you're like, let's not go there, because it could be a thrombus from an old IV, it could be just a stagnant vein, it could have some scarring in it, and that's why it's not emptying and filling like it should. So these are just hints for you guys. Moist heat, I love moist heat. So if you've seen me down there, you know I love moist heat. Those little ladies with skin this color that you see nothing, you put some moist heat on there and you got blue veins all over the place. And especially the old ladies with the bat wings. So it hurts to put a tourniquet down here, so you can see the veins and then put the tourniquet down here over some gauze. So anyway, but if you get the thing too hot, it makes their skin pink, and then you can't see the vein anymore. So be careful not to, and don't microwave anything, please. So those are my big tips. They might help you. I've been doing this a minute, and these are just some references. So, anybody have any questions?
Something kind of unrelated, but what about valves? Identifying valves or avoiding them, or?
I'm not a lot of times I think you can get through valves, because I had a lady yesterday, she had 3. And they appear as just a lump. I have a great one right here. Yeah, I got a big lump right there. You can see it. And it's a valve. But you can go through them. They are flappy.
But don't they hurt going through there? Don't they hurt more?
I don't find that they do. I think you hurt if you scrape the bottom of the vein. Yeah. But I don't think they hurt. I've never had anybody go when I push the catheter in. So, yeah, I had a lady, I think, when I went through 2 valves yesterday. And she was in pre-op. Yeah, she'd had some chemo and stuff.
I have 2 questions. One, can we palpate the vein before we clean it?
Oh, yeah, that's what you should do.
Oh, okay.
Yes.
When you said no palpating, I just.
No, after cleaning.
Right.
I'm sorry. I should
Right.
be very clear. Yeah.
And I forgot.
Oh, I have a question. You mentioned this site here. Does that also include?
Oh, that's
There's
a really
nerve
good.
right here.
There is a nerve right there. It includes here.
Because a
Now-
lot of people put them right there.
Yes, they do.
And I've had one placed there and it was excruciating.
It is, because and there is a nerve there, and there's something else you should know about that place.
Should not place there.
We dealt with a lot of heart patients at my last hospital, and in 2 days, I ran into 2 people that had an artery where their cephalic vein should be. One of them I went, oh my, that's an artery, and he goes, yeah, I wish the people in the ER had known that. So always palpate that vein, because some people with certain heart conditions, it's flipped.
Should we go at least 3 fingers
You should,
above?
3 fingers above there. Now, the back of the wrist is a little different. You don't have all the nerves there. Yeah, you're right.
Like this way, you mean?
Yeah, there's not a lot on the back of the arm.
I thought of my second question. So if we are inserting an IV and we go through the vein and it bleeds and you pull it out and you put pressure on it,
Mhm.
is that a higher infection rate for the patient?
No, it's every entry into a vein increases the
Okay.
infection risk.
Not-
So,
Not because we blew it?
no, not because you blew it.
Okay.
No.
So I have one more question. We have patients that are notoriously difficult, and the IV team usually wants us to try twice before they will try. Can we work on that?
Ignore the IB team, okay? Yeah, I'm gonna tell you what I tell everybody. If you don't see a viable vein, do not apologize. I don't see a viable vein. Please come look at this patient. I don't want to hurt them. We can't argue with that, okay?
You got one that does.
Put in your,
But I've been
yeah,
asked
and I will talk,
if I've
I will
tried
talk,
twice.
I will talk to the team. I don't recommend anybody try even once if you don't see something that you're not about 80% sure about getting.
Nice.
There.
Good.
I'm sorry, but that's how I feel. I get, you guys do this a lot, but not as much as we do. And we do have, especially on days, people who can use, utilize an ultrasound. So, and I might grab the ultrasound a little sooner, especially if I know someone's been stuck 4 times, because let's elevate the technology here. That's my thought process. And if anybody ever wants to learn ultrasound, call me. I'm the ultrasound queen, so I don't know how many hundreds I've put in, so. I mean, and they're not that deep a lot of times. A lot of times they're only like 0.2 centimeters or 3 centimeters deep. It's just that you can't feel them because of the tissue, the little grainy little nodules that you feel sometimes.
I see anesthesia sometimes reuse their lidocaine sub-Q needle. That's a big no-no, right? Once you stuck it in one spot. you
Yeah,
can't
I
stick it
wouldn't.
in one.
No,
Do you
I
guys
didn't even
try-
know they used it.
We
Yeah,
do
me
it.
neither.
Well, that's nice of
When
you.
they come to help us, they
Yeah.
use ours. I
Oh,
don't know
okay.
that they do on their own.
Yeah, no, you shouldn't reuse it.
And do you guys educate the new anesthesia guys coming through? Do you do
How about
this?
the old?
No, we do.
I was just gonna say,
Right, we do.
or it's more
Yeah,
us.
I don't know
I
what the
think that
education's
comes from
been.
when they're doing other lidocaine preps. They'll clean the site and they'll use the same needle in more than one
No,
spot.
that comes with IV
That's where that
starts.
comes from.
They do it with IV starts.
No, I know they do,
Yeah,
but
that's why they do
where
it.
it's coming
Why
from
they
is
do it
that,
that way.
when they're doing blocks and stuff, they
Oh.
will use the same needle.
And that is clean to do it for blocks because they're clean the skin, or?
No, I'm sure it's not.
Okay,
I would.
good to know, because
Any
I just say,
situation.
here, I have another one, but
Yeah.
it just blows my mind to
Yeah,
watch
sometimes
them.
it's bad when you're handing them another catheter because they've tried it and they still got it in their hand.
Yes,
Yeah.
Yeah, it's like, ooh.
Yeah.
So, I hope this helps a little.
Oh, it's
Yes.
awesome. Thank you.
Very good.
What is our infection rate? How, do we hear back if someone comes?
Ours is
up?
pretty low. Ours is pretty low, yeah. The ones that have been a problem are multiple sticks, and there have been, but it's really hard to really say this is what caused the infection because there's so many other procedures. But I would say, especially that one lady, it was an EMS placed IV because of the timeline. And it takes about 3 or 4 days, and then the whites are coming up, and and she goes home because everything's all better, and then comes back in and.
I had a patient
Yeah.
just tell me that they had an endoscopy and got an infection from the IV site. And I would love it if pre-op got that feedback back. if
Yeah,
we-
I'm not, there's a, and I don't know, there's a rumor that not everybody in the house still uses ChloraPrep. So
Oh.
there's some rumors out there, so.
I have a
Yeah.
question, and I don't know if I'm wording this correctly or not, but you said for patients that are getting outpatient procedures, so, if they're getting in and they're getting out the same day, we can just always choose the bigger IV for
Yeah.
resuscitation. And there's been times where I see like a good vein, but it doesn't look like it's gonna fit an 18, or when you think about trying.
Well, then don't even try.
So don't even try for the
No.
18, just.
No, because what you're doing is trauma and another insertion. And, you have to use your judgment, If you put heat on and you still don't think, and there are those tricky veins, the veins. The guys that come in and they look like I got ropes before you even put a tourniquet on. And it doesn't get bigger when you put the tourniquet on it, so it's like, oh, let's not go there. That just means the vein wall is really thick. And you're gonna have a hard time, probably. Yeah. So you guys all have seen them, haven't you? You go, wow, that's huge. What the? Yeah, that's what it is. The vein wall is so thick. They did some kind of work or, and the vein walls are really thick. Yeah. So if it doesn't get bigger, don't stick it. Yeah.
Just to clarify, so you're saying when we start the IV, we should, when you get it in, put the tegaderm on, and then put your hand over the
Right,
tegaderm?
because if you hold that without the tegaderm on, then you're just contaminating under the dressing, so, you know. And we used to have kits, and I would take the the little gauze, the sterile gauze, and hold the site, and then hook up, and then put the dressing on and everything, in another world. But we don't have those here, so I put the Tegaderm on and hold over the Tegaderm, so,
Before you remove your.
yes.
Yeah, Amy Wilson
Yeah.
actually taught us that a long time ago.
Yeah.
Is that a policy or is that just kind of best practice?
Well, I think it's just best practice. I don't know if it's in the policy, it's in our checkoff sheet.
I do it because then you're, less risk of it getting pulled out somehow, or when you're drawing labs, I do the Tegaderm before I remove it.
Every now and then we have people that are allergic to Tegaderm, and then is the sterile 4x4 the best practice to tape over the site?
That's what they recommend, yes. We do have IV 3000,
We have that too.
yeah. So,
That's what we've been using.
yeah, the IV 3000 is nice. It's, hardly anyone is allergic to it. And a lot of times people aren't allergic to the Tegaderm. It's because someone used Tegaderm without letting the ChlorPrep dry, and they got red. Yep.
Yeah, sometimes they get itchy under there, right?
Yeah.
From that.
Yeah, because, and the ChlorPrep does persist on the skin. You can feel it if it's on your, yeah, it's kind of sticky, so. But you can email me and whatever, if you have questions. I'm Ann King, there's a couple Ann Kings.
How are we doing with how we tape them? Like, have you heard of complaints on the floors? Like, oh, it's like.
No, I haven't heard of complaints, as long as you don't put tape under the dressing, We use the stat locks because we hope that they're gonna be in for 4 days, And the stat locks have been shown, and ours lock right on the catheter, and it's been shown that a stable IV is a great IV.
We have one of those ultrasound, what is that thing, a vein
A
finder?
vein finder,
Do
yeah.
you have any advice? Because I feel like sometimes it all depends on how far away I'm holding it over the vein. It might look huge, and then you put it down, and it's like, oh, that's. not
Yeah, they
good.
only show superficial veins. That's the thing,
Mm-hmm.
yeah. Yeah, they don't show deep veins, yeah, and like, some of we don't even have one, I wish we did. We have a little wee light, but that's all we have. So, I wanna get one, but.
They are
What's it called? What
expensive.
kind of
It's a
light?
wee light, it's red, infrared, you can put the baby's hand on it, it's a wonderful thing for little boy, little fellas, yeah. Yeah, I use them religiously, because you can really check the fill and stuff, yeah. I don't know if you guys do babies. Real little. Woo.
All right. Thank you,
Thank
Ann,
you.
very much for
Thank you.
coming.